I think all of you will agree with me. These days, medical laboratory has assumed a central place in any healthcare organization, and you must have realized during COVID-19 also recently, you cannot make the diagnosis of COVID-19 without laboratory, and still laboratory is playing such an important role. You cannot travel at most of the places without a negative RT-PCR report in your hand. And what government in every country want to ensure, whatever report a laboratory is releasing, that report shall be meaningful, that report shall be accurate. We are generating so much information in our laboratory, sometimes qualitative, sometimes quantitative or descriptive. And this information generated by us is then applied by a clinician in a particular situation for better patient outcome. What is their expectation? Report shall be accurate so that it remains meaningful for them. And since ages, we are measuring everything in our laboratory according to our understanding, according to our experience. And there was a lot of subjectivity associated. And this was happening globally. So people realized all across the globe, we shall have a system so that reported generated in one laboratory or in one institution shall remain meaningful for people who have to take decision at some distance place. So what was our intention? Objectivity. Similarly, within laboratory also, when we are saying we are following quality, we are performing different activity, so how we can develop objectivity, whatever we are communicating, how we can develop objectivity so that that information is more meaningful for clinician. In fact, 70% clinical decisions are based on our report. Our intention is to release error-free report so that it remains meaningful for clinician. They can make correct diagnosis, they can start correct treatment, and as a laboratory person, ultimately we are involved in the better patient care. For this, what we are doing, we are assuring them we are maintaining quality. What is the basis of this assurance? We have good quality control in place, which is involving not only examination part, but pre-examination as well as post-examination. And they may ask, what is the basis? How you are assuring or you are maintaining quality? There also may be a lot of subjectivity. Then you're telling them, we have developed a well-defined quality management system, quality manual, quality system procedures, standard operating procedures, sample collection manual, lab safety manual. We have created so many formats. People are filling those formats. So there is a system in place. It is not like that. People are working as their own understanding and knowledge. We have developed a system and we have trained our people accordingly. Now, look at this quality management system. Many of you have attended ISO 15189 training program. You know, what are all these requirements? You may be wondering why I'm discussing all these things, because we have to apply Six Sigma and lean concept in these areas. This we have to understand how we can apply. With Sigma matrices, we improve quality, and with lean concept, we remove wasteful expenditure. When a patient comes to us, patient comes with a request in his or her hand, we collect samples. We take care all the pre-examination requirement. If suppose somebody want to know What are the precautions required before coming for this particular sample? So we are telling them, if suppose somebody want to know, a clinician want to know how this sample shall be collected or how much volume of this sample shall be collected, we are helping them in this. These are advisory services. If suppose we are sending some sample to outside laboratory, we are informing patient, we are not performing this test will be performed in some other lab. We have well-defined system of selecting that lab. If we are performing some tests in our laboratory, we have properly validated tests. We are taking all precautions. We are participating in IQC and EQUAS. If we are receiving some report from referral laboratory, either we are printing on our stationery or we are handing over as it is, whatever is the system, we are maintaining all records and checking for transcription error. If suppose somebody wants to know what is the interpretation of a particular test, we are helping them. We have defined, we correlate all tests clinically and with previous result, that is called delta check. We have defined contents of our reports. We are releasing various type of report, what should be the content, what should be the presentation, and we are releasing results only to authorized signatory. These are the different activities in all laboratories. And to perform all these activities in a required manner and how we can improve. If there is any complaint, we take that seriously. We do root cause analysis and we document everything. Within the lab also, we see how we are performing various activities. If there is something which is not as per our defined procedure, we note down that and we take appropriate action, whether it is corrective action, preventive action, and we look for continual improvement. Continual improvement means stepwise improvement. At present, suppose you are not performing molecular testing, you're saying, okay, I will start molecular. These days, this RT-PCR for COVID-19 is in demand. I will start with this, then I will expand my menu. Later on, you are saying, I will start cytogenetics also, or immunohistochemistry also in surgical pathology, or in microbiology. Right now, I am doing culture by manual method. I will go for automation, or I am doing culture by automation method. I will start point of care testing in the identification of organisms. What are these? These are continual improvement. We are improving our services and we are regularly auditing our activities so that we are able to find out if this procedure needs some improvement or this procedure is okay, but implementation is not okay. We have to improve our implementation. And we are regularly participating in EQUAS. We are regularly participating in IQC. For this, what we have done, we have defined our organization. We have defined management responsibility. They are senior persons. They are involved in various activities of the laboratory. How a laboratory is performing all these activities. What are the requirements of users? We are defining that. How we will work. We will talk to our stakeholders who are affected by our services. Regularly, we are discussing with the top management. They come to know how we are providing our services. We also, if need something, we can discuss with them. We have defined our quality management system. We have prepared documents as per our defined quality management system, and we are maintaining various records. And we are maintaining records in such a manner, these are easily retrievable and retrievable in legible manner. For this, we have appointed qualified people. They are trained and regularly we evaluate them. They are participating in conferences, seminars, etc. And we maintain all records. We have allocated adequate and appropriate space for laboratory activities and we are maintaining that. We are providing facilities to staff also. We have collection area separately so that privacy of the patient is not compromised. We are maintaining all the requirements of our equipments, reagents and consumables, and we maintain all records of our equipments as per IQ, OQ, PQ, installation qualification, operational qualification, and performance qualification. We are evaluating our vendors. We have list of vendors, what all we will purchase from a particular vendor, and we are maintaining our laboratory information system in such a manner we are not losing any information and confidentiality of the patient is maintained. So now, sometimes what happens, people say, what is the need of this accreditation? We are maintaining very good quality. That is okay. All of us are performing all these activities only in our laboratory. But if we start following ISO 15189, then we get a system, we follow a system. And if we go for accreditation, an external body is checking our activities and they can tell us, see, you're performing this activity, but there is a scope of improvement. If you slightly modify, if you add this, your performance will definitely improve. In some countries, accreditation is a mandatory requirement. That is why you are going for that. Like in India at present, for this COVID-19 RT-PCR, accreditation is a mandatory requirement for private laboratories. Now look at this picture. As we discussed, we are receiving a request, we are collecting sample, we are transporting sample, we are receiving samples in the laboratory. Then any preparation is required. We need to suppose prepare some aliquots to distribute in different laboratories. We are doing that. Then sample is reaching at the examination counter. They are entering information in their computer. They are performing tests as per defined procedures. Results are interpreted and reported. If critical results, informed to clinician. Every laboratory is performing these activities. Then where is the difference? When we say this laboratory is good, this laboratory is not so good, where is the difference? Yes, Rashmi Shetty, please unmute yourself. Risha, please unmute yourself. Preeti Kumari, please unmute yourself.
Hello. Good morning, sir.
Yes, Preeti.
Yes, good morning, sir.
I am saying every laboratory is following the same procedure. Then where is the difference? When we say one laboratory is good, another laboratory is not so good, where is the difference? Almost every laboratory is following the same sequence of events.
Sir, somewhere the documentation is not to be complete or their documentation.
Yes, excellent. You're 100%. Yes, very good. See, now, same flow of activity, but at every step, there is a well-defined procedure. What you have to do, you have to develop a procedure. At each step, how you will carry out that activity. One thing is development of procedure, and another thing is implementation as per your defined procedure. This is the difference between laboratory to laboratory. How strong is their system? They have developed procedures and they are implementing. Their people, they are getting training how they have to work as per their defined procedure. So how we can evaluate these different activities, whether we are performing these activities in a required manner or not. For this, we can use this Six Sigma matrices. This tells us about method quality. We can compare equipment. We can optimize our QC procedures. How frequently we will run this QC? Once in a day or twice in a day? How many controls we will run? 1 level, 2 level, 3 level? How many rules need to be applied? We get information about these things. We come to know about process outcome and process variation. So this we will discuss. What is the meaning of this process variation and process outcome? And ultimately, we are able to evaluate performance of different laboratories. If suppose some clinician has to decide, there are 3 laboratories and he wants to send his T3, T4, TSH cases to one laboratory. How the clinician will decide which laboratory is good for him or which laboratory is best for him out of these 3 laboratories? Dr. Manjari Kishore, please unmute yourself.
Hello.
Yes, Dr. Manjari. Would you like to share your thoughts? If suppose some clinician has to decide out of these 3 laboratories, which laboratory will provide best results? So how the clinician will decide?
So for the clinicians, they mainly rely on the turnaround time.
Right.
And like, actually it varies from the department to department, like if they are asking for the pathology or the biochemistry or this.
Okay. Suppose what is your specialty?
The pathology.
Pathology. Suppose this is related to hematology report.
Yeah.
Hematology report of CBC. Where
Yeah.
if you ask investigation, then how they will decide?
So like if the suppose CBC, the parameters are not matching, like if like yesterday you were saying about the MCB thing, if suppose like hemoglobin, HCT and RBC. So usually we follow the rule of 3. Once we see that, but if it varies, then we have to look before dispatching the report.
No. I am asking how the clinician will decide which laboratory is best for him out of 3 laboratories. There is no set system, right?
Yeah, because it will varies from clinician to clinician also.
So now, when we will finish this, Dr. Manjari, you please note down, then ask me how the clinician will decide, then I will explain, right?
Yes, sir.
Okay. See, if suppose somebody want to evaluate which laboratory is best for him, there is a lot of subjectivity. So how we can develop objectivity in it, that we will discuss. Can you identify who is this gentleman? Please write in the chat box. What are these sigma matrices? Sigma means standard deviation. In this, what we do, we count errors in a particular area. Then we convert these into defect per million opportunity. DPMO means defect per million opportunity. And then with the help of a table, we convert this defect per million opportunities into sigma matrices. And closer these are to 6, better is the situation. Ideally, these should be as close to 6 as possible. And if these are more than 6, so this is a acceptable situation. If suppose sigma matrix is 6, then there is a possibility of 3.4 defects. Defects means unacceptable situation per million opportunity. What I mean to say, if suppose you want to see performance of laboratory related to unlabeled samples. How many samples received in the laboratory are unlabeled or not completely labeled? Some labeling error. You want to see labeling error, and in this you are including unlabeled sample or not completely labeled samples. And in 1 month, if you are collecting 3,000 samples, out of these, 3 samples are not labeled properly. 3 samples out of 3,000. So now you are converting this into million. That means 3,000 means 30,000, 3 lakhs, 9 lakhs. So that means if there are 3 per 3,000, 330, 300, almost 9, you can say around 1,000 incorrectly labeled samples out of 1 million. So that means sigma score is somewhere between 4 to 5. So this, just for our understanding purpose, I have used only whole numbers. Otherwise, with the defect per million, the sigma matrix, you can have 1.1, 2.1, 1.1, 1.2, 1.3 like that, complete table, and you can correlate with that, which is matching more perfectly. The ideal situation is 3.4. And initially, this Motorola company or General Motors, they started this concept of sigma matrix in their industry. Later on, many industries started, and you can apply this to any situation. And now many airlines also, they are following this. And how we can apply this in our laboratory, that we will see. This is telling us about process outcome. This is outcome of a process. There are so many labeling errors out of these opportunities, or so many test request form not properly filled. In some case, history is missing, or date of collection is missing, or who has performed the surgery, that is missing, or nature of the specimen is missing. We are considering all these under one heading, test request form not properly filled. What is this? This is process outcome. We are checking how many defects we are getting per million, and we can convert that into sigma matrix. And over a period of time, we can see previously sigma matrix was 4.2 and now it is 5.1. That means situation has improved, and there is objectivity in it. If suppose you are talking to clinician, you can say we are not getting test request form properly filled. This is the situation. These many different problems we are facing. And at present we calculated this sigma matrix. This is 4.2. So now the head of the department of surgery, he is informing their residents, other surgeons, you please send properly filled test request form along with specimen. And after 3 months or 4 months, in another meeting, the person is asking, are you finding any improvement? You're saying, yes, sir, thank you very much. Now the situation has improved significantly. From 4.2, sigma matrix has increased to 5.3. So now there is objectivity in the system. Even if you have in the management some non-technical person who has understanding of this sigma matrix, basic understanding, it should be as close to 6 as possible, then that person will also understand, yes, there is improvement in this area. So when you will start applying sigma matrix in different activities of the laboratory, then you can see what was happening previously and how much you have improved in this area. And if suppose some organization has multiple laboratories, now you have so many chains of laboratories, not only India, all across the globe. You have suppose 20 laboratories. In your headquarters, you can prepare a chart. These are the various activities which we want to evaluate. And this is the situation in our different laboratories. So you can see what is happening in different laboratories, where the Six Sigma score is less, where the Six Sigma score is appropriate. And you can prepare a report. In these different laboratories, they require improvement in this particular area. This laboratory requires improvement in this particular area. So that way, you can start applying this sigma matrix in your individual laboratory or in your chain of laboratories. Yes, Dr. Mohammad Zarif, please unmute yourself.
Hello, sir. Good morning, sir.
Morning, Zarif. What is your feeling? This is useful or not?
Yeah, very useful, sir. This one, because there is a subjectivity.
Huh.
We can decide our improvement. Improvement. We can monitor our improvement, and we can decide our plan accordingly.
Actually, this concept is very good. Only thing we have to understand, and that we learn with experience, how we can apply this concept in various activities of our laboratory or various activities related to our healthcare, right?
Right.
For this, we will understand some basic concepts. One thing is bias. These days it is also called as trueness. Lab result minus group mean divided by group mean. And generally in our laboratory we get this group mean from our equas. So we can use this bias. To calculate bias, we can use information given in the equas. Lab result minus group mean divided by group mean into 100, that is bias percentage. That tells us about trueness or accuracy. Imprecision, this information we get from our IQC data. CV%, standard deviation divided by lab mean into 100. So this information we are getting from our IQC. The bias we are getting from our equas, and imprecision, that is CV%, we are getting from our IQC. So now we have to understand application of this Six Sigma. One is process outcome and another is process variation. Process outcome means when we are carrying out some activity, there is some result of that activity. When you are collecting sample, either your collection is successful or there is failure in the collection. If you want to see in how many cases double prick was required, that means there was in the first attempt venipuncture failure. If you want to see that, suppose out of you have collected 1000 samples in 1 month, and out of these in 4 cases there was venipuncture failure. That means out of 1 million, it was observed in 4000 cases. So then you can convert this into Sigma matrices. This is process outcome. Or suppose, what I'm saying, you can apply this in any situation. Suppose you have 10 employees in your laboratory. You want to see their punctuality. You are finding when they are coming to organization, or how many times they are reaching organization after defined time, or they are going early. So you can make a record of that. In 1 year, suppose person was supposed to come to organization on 300 days. Out of 365 days, he was supposed to come on 300 days. Out of 300 days, how many times he came late or went early? So that means total events possible were 600. So out of these 600, in how many times there was some error? You can tabulate that for your employees, and after that you can calculate sigma score. These people, they are working with sigma score of 5.6, these with 5.2, these with 5.0. Then you will have objectivity in their performance related to punctuality. So similarly, we can apply this in different situations. This we will see what is the meaning of this process variation. Process outcome is number of defects. As we discussed, we are converting these into defects per million opportunity. And then with the table, we are correlating with this sigma matrices. And over a period of time, we see how much is the improvement in this sigma matrix. We can apply this to any situation. Pre-examination, examination, post-examination, so that we have control over the whole process in our laboratory. Now, we are talking about process variation. This is related to our testing activity. How much variation we are getting. So bias percentage we calculated from our IQVAS. CV percent we calculated from our IQC. We discussed earlier. Total error allowable. This we get from our the literature. There is one guideline by C. Ricos. In Westgard website also, they have mentioned total error allowable of different analytes. What is required? This bias should be as minimum as possible. This CV percent should be as minimum as possible. With this, we are calculating sigma matrix. If bias is low, so total error allowable minus bias, this difference will be high. When this difference is high, so you will get higher sigma score because this is numerator. If this CV is low, you will get higher sigma score because this is denominator. We have to understand these should be as minimum as possible. In our healthcare, we say minimum acceptable performance is 3 sigma in any situation, and world-class performance is 6 sigma. So whatever 6 sigma at present we are getting, we have to increase that. This we have to understand. And we use another term, quality goal index. This is bias which we calculate from the AQUAS, and 1.5 multiplied by CV, and this CV we are getting from IQC. If it is less than 8, less than 0.8, that means CV is high. There is imprecision. If it is more than 1.2, that means bias is high, variation is high, there is inaccuracy. If it is between 0.8 to 1.2, that means there is imprecision as well as inaccuracy. Now you may say, then what is left? It will be either less than 0.8 or more than 1.2 or between 0.8 to 1.2. What is the relevance of this? That we will discuss. We will understand that. First, we are discussing what is this quality goal index and how it is interpreted. If it is less than 0.8 imprecision, more than 1.2 inaccuracy, 0.8 to 1.2, both this imprecision as well as inaccuracy, both are operating. Many times you see this type of chart and this is very confusing. What we do, we write percentage CV on x-axis, percentage bias on y-axis, and we see how various tests they are performing. In this, what is our intention? This imprecision and inaccuracy should be as minimum as possible. So that means we shall have most of the analyte near the starting point. As they are moving away from the starting point, quality decreases. So this is what they want to show through this chart. Because when we see this, we find it little complicated. But when you will understand what is our intention while discussing this, then you will understand that most of the analytes should be as close to initial point as possible. So at present, there is no need to start drawing this for your laboratory. First you understand, start understanding, start applying this 6 sigma in various activities. Then in some other lecture, we will discuss certain things which are more complicated, because my intention is always first learn fundamentals, and teaching and understanding should be as simple as possible. When you are reading something, read in such a manner. After reading, reopening of the book is not required. And when you are teaching someone, teach in such a manner the person doesn't have any requirement now to open the book. He should be able to understand. So these should be the quality in a student and in a teacher. Now look at this table. In our laboratory, we analyze 10 parameters. We analyze 10 parameters, and these are the CV% observed over a period of 6 months for these 10 analytes. March, April, May, June, July, August in 2019, and we calculated average CV%. Then we calculated bias percentage from Equa scheme. For a period of 6 months. These are the bias percentages, and we calculated the average also. Now we have CV%, we have bias percentage for the same time period. CV from IQC, bias from Equas. And we got this total error allowable from the literature. Now we have total error allowable, we have average bias percentage, we have average CV percentage, and we calculated sigma score and QGI ratio, quality goal index. So sigma score, total error allowable minus bias percentage divided by CV, and quality goal index, bias percentage divided by 1.5 into CV. So now we have this data with us. In some parameters, Six Sigma score is less. In some parameter, it is good. Then now, how this data will be analyzed? We are finding this Six Sigma level. Above 6, we have observed in 2, SGOT and magnesium. Between 5.9 to 3 in 4, albumin, SGPT, calcium and urea. Less than 3, creatinine, glucose, potassium and total protein. And we discussed minimum acceptable performance is 3. Minimum acceptable performance is 3. So now above 3, both these situations we are accepting, although performance is close to world-class level in SGOT and magnesium, but it requires improvement in albumin, SGPT, calcium and urea. But creatinine, glucose, potassium and total protein, this is not acceptable at all. So in this situation, less than 3, which is not acceptable, here we will see what is the quality goal index. So in this table, we will see only creatinine, glucose, potassium and total protein. Creatinine, 6 sigma score 2.3, quality goal index 0.6. So if it is less than 0.6, what is this? There is imprecision, CV is high. That means variation in the IQC is high. Glucose 2.3, quality goal index 1.0, 0.8 to 1.2, that means there is imprecision as well as inaccuracy. Total protein 2.9, 1.0, quality goal index, imprecision as well as inaccuracy. And what was the fourth? Potassium 1.5, 6 sigma score, quality goal index 1.2. There is imprecision as well as inaccuracy, and this is on the higher side. If this is close to, you can say, more than 1.2 type, so there is more inaccuracy. The bias is high. So that is how we get the information. What is the problem in this particular analyte? It is inaccuracy or imprecision. So that way we can develop our understanding and what is the action required in a particular situation. So for this we have to observe different conditions of our laboratory and how we can take action in that. And based on Six Sigma, based on this Sigma matrix, we can design. See, whatever I have mentioned here, this is not essential. What I mean to say, you can design. If suppose your Six Sigma score is high, that means you are getting less number of errors. You are getting less variation in your process of this examination. You can reduce the frequency of control samples. And how many times, how many level of control you want to run, and how many Westgard you want to apply. Risha, please unmute yourself.
Good morning, sir.
Good morning, Risha. First, introduce yourself.
Sir, actually, I'm Dr. Sabah Siddiqui. Risha is my daughter.
Okay.
Yeah.
So, where are you from?
Sir, I'm from Aurangabad, Maharashtra.
Okay. Right. So, you want to discuss this particular chart?
Yes, sir.
Okay. So, what is the query you have related to this chart?
Sir, Sigma and how we can apply this Sigma matrix and quality goal index by this chart. Like, again, I want to understand this.
I explained you how we calculate Six Sigma. We calculate
yes, sir.
by total error allowable minus twice percentage divided by CV percentage.
Yes, sir.
And in this particular chart, with this information, total error allowable minus bias percentage divided by CV, we calculated Six Sigma score. And Sigma score.
Yes. Mm-hmm.
And when we divided bias percentage with 1.5 into CV, we got this quality goal index.
Yes,
so
sir.
Calculation we discussed earlier here, right?
Right, sir.
Now, we have discovered Six Sigma score and quality goal index, and we discussed we will use this quality goal index when a Six Sigma performance is not acceptable, that is less than 3. So now we are observing only those situations where the Six Sigma score is less than 3. So in this, we have some other analytes which are not part of this study, but we analyze those. Here we are discussing creatine, glucose, potassium, and total protein, which we those 10 cases. So in 4 cases, creatine, glucose, potassium, and total protein, Sigma score is less than 3. So now, what is the quality goal index here? This we have to see. If it is less than 0.8, so that means CV is high, there is imprecision. If it is more than 1.2, that means bias percentage is high. There is inaccuracy.
Right.
If 0.8 to 1.2, so that means both are operating. There is inaccuracy as well as imprecision. So first we have to understand what exactly is operating in this situation, and then we have to take appropriate action, right?
Right. Thank you, sir.
Welcome. So then, this is just an example. We can use this information in deciding how frequently we want to run control, how many controls we will run, how many Westgard rules we will apply. If suppose some laboratory is operating at 6 sigma level, that means it has very less bias, very less CV percentage. That means there is very less inaccuracy and imprecision. They can reduce the frequency of number of controls. They can reduce number of controls, they can reduce frequency, they can reduce number of Westgard rules applied. But if 6 sigma score is decreasing, that means their analytical system is not that perfect. So then they have to increase the frequency of control. They have to increase the number of controls they are running. They have to increase the Westgard rules which they are using. So at present, it will look little confusing. So my purpose is not to tell you कि 1 per 1000 or 1 per 450. These I have taken arbitrary figures just to explain you the concept. As our performance decreasing, we have to be more vigilant, more careful. We have to apply more rules to understand. Yes, Amanpreet, please unmute yourself.
हेलो गुड मॉर्निंग सर। सर मुझे ये पूछना था कि जैसे वेस्टगार्ड रूल्स है वो क्या सारे फॉलो करने होते हैं या आप अपने अकॉर्डिंग फॉलो कर सकते हैं?
आप अपने अकॉर्डिंग फॉलो कर सकते हैं।
ओके, तो ऐसा जरूरी नहीं है कि सारे ही फॉलो करने हैं हम।
इसमें जब हम ये जितनी भी बात करते हैं ना रूल्स की, क्वालिटी कंट्रोल की, generally people start talking about all these things when they plan to go for accreditation, right?
Okay.
In 189, they have not mentioned how many controls you will run, how frequently you will run, Westgard rules you will apply, or whether you need to apply Westgard rules at all or not. Mentioning anything about that.
Okay.
But if accreditation body is putting some restriction, you have to do that. But in also they are not talking, you have to apply so many rules. But whatever you are doing, you should be able to justify. If suppose saying I am applying 1 3S and 2 2S, and you are getting very frequent outliers, definitely the assessor will ask, you are not improving your quality. At present, your quality is not satisfactory. There may be errors in the patient result. Ultimately, what is your intention? We want to reduce errors in the patient result. That is why we are performing all these activities. So, what you can do, in the beginning, you start with 1 2S, 1 3S and 2 2S. Then you start looking at more rules. When you in these rules you are not getting any outlier, you are getting satisfactory performance, then you can reduce the number of rules you are applying.
Like in start we have to like follow some rules and eventually we can go higher.
Yeah.
Okay. Thank you, sir.
And we discussed yesterday systematic error, which is affecting your many results. So What may be the reason? Change in the reagent, change in the control, or machine is not maintained in a required manner. You also see when the machine was calibrated, there is no change in the lot of calibrator or controls. See about the maintenance or service of the machine. Any change in the lamp or lamp may deteriorate. Shelf life of a reagent, onboard stability of a reagent, you can see after reconstitution. And you can check if suppose some other person, they also using same machine, same reagents, what is the mean NSD they are getting, what is the mean NSD you are getting. If suppose you are getting lower mean NSD, it is possible consistently you are getting lower values. When there is a random error, see whether the control is mixed properly or not after bringing to room temperature or after reconstitution. There is no bubble, because if suppose machine has aspirated a bubble, it will show low result for the control. Shelf life of reconstituted control, it is not used after that expiry. Temperature and humidity of the environment and instrument. One day, if suppose there is some abnormality, some problem, it can affect your random result. Calibration status, electricity fluctuation, some lot change, any instrument error, suppose there is some leakage or some block in the aspiration tube. So, and after repeating, if you are not finding any problem, you are repeating control. If it is, see whether it is okay or not. If it is okay, so that means probably it was a random error. Process outcome, we see process variation, we see in our examination process. Process outcome, we see in our pre-analytical, analytical, and post-analytical part. Various activities like your sample collection, sample labeling, or you can say identification of the patient. Number of patients who have not followed instructions provided to them. If suppose there are significant number of persons, you have to see how you are communicating these instructions to them. Why they are not able to follow that? That means you have to modify how you are explaining that. Process outcome in analytical. The number of EDTA samples required remixing. In the beginning, when these were submitted to machine for your CBC analysis, these were not mixed properly. So this is process outcome. Number of outliers you have observed in 1 month in IQC. Previously we checked variation. based on our IQC class. Here we are checking number of outliers observed. Suppose in the month of January you observed 10 outliers. You were analyzing for 20 analytes, 2-level control twice a day. That means every day you are analyzing single analyte 4 times, 2-level control twice a day. And if suppose you have 25 analytes, so that means you are running control 100 times daily. In 1 month, you are running 3000 times. Out of these 3000, how many times you are getting unacceptable performance, which requires some action. Acceptable performance, which requires some action. So you are converting that into defect per million opportunity, converting to Six Sigma matrix. In the month of January, our IQC performance was at suppose 4.6 Sigma matrix. Month of February 4.9, 5.0, and suppose in July you are getting performance at 3.2. So that means something has happened. What is the reason? Has the operator changed, or what is the reason? You can apply Six Sigma in your aqueous performance in this checking process outcome as well as in checking process variation. Same is true for your post analytical. You are releasing results released to wrong person. How many times? What were the opportunities? Report typed incorrectly. That also you can see. That way we can check process variation as well as process outcome. For this, where the change is required, Dr. P. Santhil, please unmute yourself.
Yes, sir. Good morning, sir.
Yes, Dr. P. Santhil.
Yes, sir. Good morning, sir.
We want to improve the quality of our services.
Yes, sir.
For this, we have selected the Six Sigma matrix. We will follow Sigma matrix. This Sigma matrix should improve. This should come to as close to 6 as possible.
Yes, sir.
Suppose we want to do where the change is required.
I have to see every steps, sir.
Yes.
Unless who is responsible. How to apply any double checking or single checking.
To bring this change, what is required?
And the quality system procedures, we have to improve everything, sir.
One thing is, we shall not consider this as a burden. Okay, this is burden on us. This is imposed on us. We should accept this happily. Am I right?
Yes, sir. Fine.
For this, where the change is required, we require changes in our habits. Whether it is related to exercise, whether this is related to food habits, only a change in habit will provide results. Yes, Dr. Palekar, please unmute yourself. Dr. Sindhu George, please unmute yourself. Amresh Pati, please unmute yourself.
Good morning, sir.
Good morning, Amresh Pati. Do you have some interest in sports?
No, sir.
No. Okay. Not even watching.
Watching, I love watching cricket.
Okay. Love watching cricket, but that will not increase your stamina, right?
Yes, sir.
But definitely you will agree with me. To improve your stamina, so you have to perform some exercise.
Yes, sir.
Just by watching Olympic on television, you cannot improve your stamina.
Yes, sir.
If
Yes,
you
sir.
reduce your weight, so you have to change habits.
Yes, sir.
Otherwise, you cannot reduce weight.
Yes, sir.
Similarly, if we want to improve quality,
Yes, sir.
if we want to improve existing quality of our laboratory, what
Yes, sir.
we need change in our habits. We have to follow certain healthy habits related to our laboratory. Only then we can improve. Right?
Yes, sir.
So now, what we need or what we expect in our laboratory, we want to improve the Sigma matrix. Now we are talking about lean concept. Lean concept is okay. First, we will discuss with a common example. Yes, Dr. Vijay Shri, please unmute yourself.
Yes, sir. Good morning, sir.
Good morning, Vijay Shri. First, introduce yourself.
Dr. Vijay Shri from Government Medical College, ESA, Coimbatore.
Okay.
Microbiologist.
Very good. Dr. Vijay Shri, what is the difference between a obese person and slim person?
I think slim person can have a good quality of life.
No. What is the difference? And these are the advantages of slim person.
Okay, sir. Obese person, the efficient.
No. I'm not asking about the advantage. What is the difference? If you are observing two persons, on what basis you will say that this person is obese and this person is slim?
Okay, sir. By the appearance.
By the appearance. Obese person has more fat and
thin person less fat.
Thin person has less fat, right?
Yes.
Even a thin person is leading a very good life, and you can say maybe better life than an obese person.
Yes, sir.
That means whatever extra fat the person is carrying, that is useful. That is not required at all.
Yes, sir.
So same thing, and that means that extra fat is waste.
Waste, yes.
Fat is not there in an obese patient. We say this is a lean person. The same lean concept we are applying in our lab activity.
Okay, sir.
We are removing wasteful expenditure. If suppose you are spending 10,000 rupees a month,
yes, sir.
That doesn't mean everything is going in developing quality. If you are able to reduce 4,000 from this 10,000 without compromising on the quality, so that 4,000 will go in your saving.
Yes.
Make you
Yes,
more
sir.
happy. Am I right?
Yes. Yes, sir.
So if you are improving sigma matrix, your
Yes, sir.
quality is improving, your productivity is improving,
Yes, sir.
and acceptability by consumer is improving. When you are applying Six Sigma in various situations, suppose you have reduced number of venipuncture failure, so definitely
Yes.
the patient will feel happy. And you are saving syringe also, you are saving needle also,
Yes. Yes.
some, you are saving some cost also, and you are able to build up your reputation. They will tell to more persons that this laboratory is good.
Yes.
Redo and repeat. You are performing test on the same sample, repeat testing. You are collecting sample again from the same patient. You are then performing test. If these will reduce, so definitely your pre-examination cost will reduce, and your examination cost will also reduce. You have
Yes.
to maintain less inventory. Your turnaround time will improve, right?
Yes, sir.
Analytical time, how much time you're taking to perform a test, that will also reduce. So ultimately, there is a happy situation in various activities in your laboratory,
Yes.
right?
Yes, sir.
So now what we will do, we will have a tea break. Then we will start our discussion again at 11:30, right?
Okay, sir. Thank you, sir. Thank you, sir.
Yes, Dr. Gaurav, please unmute yourself.
Dr. Jain, can you hear me?
Yes, Dr. Gaurav, you are clearly audible. And Dr. Gaurav, what is your opinion about this Six Sigma matrix? What do you find? Mother, do you find this really useful in our laboratory, this concept?
Yes, I do. So I can actually share an example, and that really helped in our practice. So going back to, hello?
Yes, you're audible.
Dr. Jain, can you hear me?
Yes, Dr. Gaurav, you're audible.
Okay, sorry, I lost connection. So I think the points that you raised are absolutely accurate and precise at the same time, if I may say so. So in my practice, what I have learned is that quality is meeting or exceeding your customer's expectation. And essentially, a clinician wants accurate results, convenient results, and cost-effective results if we want the patient to come back. And the example of phlebotomy is a good one. And I'll walk through one of the medical centers that I had. We brought in a new hospital information system, and in that information system, nurses had to learn how to order tests. So previously we had a paper acquisition system, and now they had to do using a electronic system. So their error rate was about 3%. So 3 per 100 orders were not getting entered correctly. And it was a difficult conversation to tell them what this was and why this was important, because we didn't want to call back 3 out of 100 patients. Till we actually converted this error rate into a sigma level. And I don't precisely remember the sigma level, but it was like a really low number, 2 sigma or 3 sigma. So the moment I wrote to the head of the emergency room that currently the nurse ordering practices are at 2 sigma level, all the bells started ringing, and everybody who was not so interested in this project suddenly became interested, because in healthcare, as you correctly pointed out, 3 sigma is the minimum acceptable performance. So we did a lot of retraining of nurses. We tracked their non-conformances, and lo and behold, they came up to 4 sigma. And few months they were even performing at 5 sigma. So that goes on to stress the importance that objective data gathering, process standardization, and then communicating with the customer in a language that they understand rather than the language that we understand, it really goes a long way. So those are my thoughts. Thank you so much for your time.
We discussed one example of process variation in relation to performance in those 10 analytes. Now we are discussing another study during the same period. This is related to process outcome. This we performed in the same time period. In 6 months, we collected 16,562 samples. Out of these, 6 were hemolyzed. Venipuncture failure was observed in 7, and number of unacceptable EDTA sample because of the clot present in that 9. Total number of pre-analytical errors were 22. Out of this, 16,562. In your chat box, we have posted one registration link and feedback form. So we need your name to generate certificate. So please fill this registration form and submit if you have not submitted yet. And feedback form, you fill and submit so that we get the information about the program. And if you have in your mind any topic which you think is important and shall be discussed in future, so you can suggest that also. The total number of errors were 22. And when sigma value was calculated, so these were the sigma score in these situations. Total number of errors 4.5, hemolyzed sample 4.9, venipuncture failure 4.8, clotted blood in EDTA 4.7. First we converted these in defect per million opportunity, and then we correlated with the 6 sigma matrices as we discussed earlier. So that is why I have not written all that information here, because procedure is same. Then we did the root cause analysis. What are the reasons of these failures? Improper training may be the reason. Improper training related to mixing of sample, how the sample shall be mixed. If these are mixed vigorously, these may get hemolyzed. If not mixed properly, clot may happen. And then this sample shall be stored under appropriate storage conditions. For that, what is required? Training and post-training evaluation. Whether they have understood the contents of training or not. So that they are able to mix sample correctly, and they are storing also under appropriate conditions. And these things are not happening in the future. What we can do, they shall get regular training and competence evaluation also. Competence is ability to use acquired knowledge and skill in practical situation. Environmental condition of sample collection area of laboratory area shall be monitored properly. And we thought we will reevaluate this sigma matrix after 6 months. And what is our aim? Our aim is to achieve sigma above 5 in pre-analytical phase. At present it is 4.5, 4.8, 4.7, 4.9. Our aim is not something which is not achievable, is slight improvement. We only want it should be above 5 in 6 months time. And in 6 months time, we were able to achieve sigma matrix above 5. So that was related to process outcome. So similarly, we can use in your hospitals also, related to nursing care, related to post-op infection. You can apply this to any situation. And what they say in Six Sigma, how this data shall be analyzed. First is we are generating data. If we are not able to achieve whatever we thought about, Six Sigma score, if it is low, first identify and state the practical problem you are defining. Yes, there is a problem. And you're checking with the data. How much is the problem? Then you're analyzing your data and you're saying this is the present situation. What is our aim? At present, Six Sigma score is 4.5. We want to achieve above 5. Now, how you will improve that situation? Whatever you want to achieve. You will find out some solution for that. As we discussed, we will conduct training. We will do post-training evaluation. We will also do competence evaluation related to sample collection, sample mixing, sample storage. And once you are achieving your aim, you have to see that whatever you have achieved, it is not going back. You are able to maintain that improved system. So then you have to monitor that everything is working well. It is not again going to previous level. When we are defining something, we have to see what exactly these customers they want. So we have to define problem according to that. If suppose you are saying, our aim is nobody has to wait for more than 1 hour in OPD area. And patients are not happy. They are saying, no, this 1 hour is not acceptable. Waiting time should not be more than 15 minutes. So you develop your system, why so much waiting is required? You can appoint more staff. You have to see, you have to look for your resources. You have to find out some solution. You are, okay, chalo, we will consider 30 minutes as a acceptable limit. We have to hear the customer voice, and we also have to see what exactly we can provide. So accordingly, we define our objective in a situation and needs of doctors, patients, staff. In our laboratory, if suppose doctors are saying this neonatal urgent bilirubin shall be available in 30 minutes. And you are saying, no, we will give in 2 hours. So that 2 hours may be too late. So you are saying at least this much time blood take to clot, and then this is the analysis time. Okay, we will give you report in 1 hour. So that way, you are defining a acceptable limit of a situation. And you are also identifying areas where Six Sigma can be applied. If suppose somebody has to wait for more than 30 minutes, this is an unacceptable situation. The number of unacceptable situations out of total number of situations. So you can apply Six Sigma. There's waiting time in the lobby. And what is the expectation of patient? One thing is, as Dr. Gaurav Sharma was also saying, a feeling of delight. Yes, Jasprit, please unmute yourself.
Yes, sir. Good afternoon.
Jasprit, what is the difference between feeling of satisfaction, feeling of happiness, and feeling of delight?
Sir, feeling of satisfaction is when the goals which you want to achieve, you have achieved.
This is
that,
satisfaction.
Yes.
Okay. Happiness?
Happiness, when the you get the appreciation from the other side.
Okay. Delight?
The goal has been achieved in the both the parameters are to the mark. Your goal as well as the feedback and appreciable.
See, there is no clear-cut definition. It is not something like 2 + 2 is equal to 4. But
yes, sir.
What I can say, I can explain with an example, because if you understand something with your day-to-day life example, then our understanding improves. See, if suppose you are going, where do you stay? You are in Noida.
Sir, I'm staying in East Nagar. I'm working at Greater Noida.
You're working at Greater Noida. Suppose from Greater Noida,
yes,
or you're from through expressway, you are going to Agra, right?
Right.
In your own car, and at some midway, you want to have some refreshment, and you are ordering for something, and your intention is it should come. You are telling that person, please provide me this. I am in hurry in 10 minutes, right? And then the person is providing you that item in 10 minutes. The taste is okay type, not very good, not very bad, but you are satisfied. So I got this in within 10 minutes, and I will finish this and I will move towards Agra. So you got feeling of satisfaction. But if you got in that in 10 minutes and taste is also good, you are happy. Okay, I stopped at the right place. I got this thing within 10 minutes and taste is also good. So next time, whenever I will come, I will stop at this place only. This is your feeling of happiness. And if suppose That person is providing you your item in 10 minutes. Taste is also good. And that person is saying you will also get a ice cream as a
Complimentary.
on a complimentary basis from our side.
Right.
So don't you think it will bring a feeling of delight? Something more than happiness. Right?
Right.
What and Dr. Gaurav Sharma used this word delight when he was explaining. What I mean to say, when a patient is coming to our laboratory, the patient should get a feeling of delight or at least happiness, because he or she already is in problem. We should take our services to that level. They are getting that feeling. That should be our aim, right? And to achieve that, whatever characteristics, whatever services we are offering, we have to see how we can improve that, and whatever performance gap we are getting when we are evaluating, so we should consider that as opportunity for improvement, and we should improve in these areas. Right, Jaspreet?
Right.
Okay. So then measure, collect data. Okay, these are the different activities which we want to monitor, and how the data will be collected, and who will collect this data. You're collecting data, you're creating some format for that. Process specification means what exactly you want to, what exactly you are expecting in that, what exactly you want to achieve. Process variation, what you are getting. So how much is the gap? This you have to find out, and how you can improve that. Then you are collecting data. After collecting, you are analyzing. Okay, and this is the Sigma score we have achieved. This is quality goal index. And what are the reasons which are obstructing our improvement? Then how we can improve in these areas? Key particular situation, what is the reason, and how we can improve in this area. If suppose we are finding lot of labeling errors, you are thinking if we start barcode on our samples, so this will improve our labeling problem. If problem is related to sample transport and hospital is building new block for IPD, and you are saying if we install pneumatic chute in our system, our quality will improve. If there are typographic errors, you are saying if our equipments are interfaced with the computer, then result will go automatically. Typographic errors will reduce. This is how we are thinking about improving various activities. And we will train our people, this will improve. And time to time, we will check their competence, whether they're able to use acquired knowledge and skill in practical situation or not. So that will improve. What is important? We want to reduce the number of errors in our system, because when these errors will reduce, our outcome will improve. Variation will reduce. When we are improving in an area, we have to see we are able to maintain that improvement. We have to work in such a manner now that improved phase is a routine for us. It is not like that we have achieved something, after some time it is again going back to previous level only. For this, what is required? Perfect monitoring and control. In the lean concept, we discussed there are different waste in the laboratory. What are these waste? Incorrect data entry, then if suppose there is incorrect data entry, you have to prepare a report again, paper wastage, or if you are preparing extra reports. Clinician is saying, send one report in my office, attach one report in the case sheet of the patient, and patient is saying, hand over one report to me. If you can develop a system, you are sharing soft copies with them, then you can avoid wastage of paper. Or reports are lying in the laboratory, patients are not collecting certain reports, they are asking on phone and they are not collecting. So you can develop a system. You are generating report and that report is being stored in the computer and you are taking out printout when a patient is coming to get the report. If so many extra steps in the process of transportation of samples, suppose your laboratory is L, your collection center is C. From C, sample is transported to L directly. If suppose from C it is going to D to E to F, there are multiple key. First the sample will go to that place, from that to the, at every step there is some waiting area. So there will be delay in the sample transport. Some sample may get lost. So you have to see this is not happening. Waiting at the time of billing, waiting at the time of sample collection, waiting at the time of collection of report. How we can reduce this? Inventory shall be managed properly. If suppose you have procured 4 kits, 2 kits are used and 2 kits somebody forgot. We have 2 kits in the refrigerator, they are ordering for new inventory. Then this is waste. What we need, how we can reduce the waste in the laboratory, non-utilized talents. Somebody can carry out a particular activity, but we are appointing different persons for different activities, and proper talent of a person is not utilized. Then we are appointing more persons, and that is waste. Similarly, we can, because every laboratory has different problem. So from our laboratory perspective, we can see what are the areas where you are finding some process variation, where you're finding some outcome, how you can apply this Six Sigma in various situations. So when we will start applying this, our understanding will improve. We will be able to apply in more areas, and definitely there will be quality improvement. This Six Sigma helps us in cost saving and resource management in a better way, and it also helps us in appropriate quality control strategy. And this is something which is not directly related to Six Sigma, but this is an important concept in our laboratory. Measurement uncertainty of measured quantity value. I always find a lot of uncertainty regarding the understanding of this measurement uncertainty. Anybody? Who is volunteering to share his or her thoughts about this concept of measurement uncertainty?
Dr. Jain, this is Dr. Sharma. As an ISO concept or as clinical application?
This is ISO concept.
Right. So my thoughts and experience have been that when ISO defined this, it took it from the ISO 17025 metrology-based standard. And when we are measuring physical objects, there is always an uncertainty on what we are measuring and how accurate our instrument is. So because 17025 is the normative reference for 15189, they took the concept. However, the problem clinically happens is that unlike physical objects, we are not measuring red blood cells and white blood cells, and surgical pathology are not like they are not metal or any kind of a physical object. So, and the other thing is that depending on the patient's condition, a certain lab value may have a diagnostic interpretation, but if you change the age or the reference range, then this lab value becomes something else. So what we have tried to do is to say that measurement of uncertainty is basically the clinical limitation of the assay. We know that in certain regions of the measurement, the assay performs very well. But then we also know that beyond a certain point, below or above a certain point, the assay starts to lose its applicability. But I know there are many more interpretations to it, and I'm very, very open to learning what your or anybody else's experience with MU has been. I don't know if MU has really changed our clinical utility of testing, but I'm all ears to hear your perspective.
Right. Thank you, Dr. Gaurav. And now I am sharing my thoughts with you. See, what the standard is saying. Laboratory shall determine measurement uncertainty for each measurement procedure in the examination phase used to report measured quantity values on patient samples. Now, what happens in our medical laboratory? Although the information generated in the laboratory is very important, and clinicians are taking decisions based on our reports, but all across the globe, practice is we are measuring only once. We are not measuring patient result 3 times or 4 times or 5 times, then we are calculating the average value. We are measuring only once, these quantitative values. So whatever information we are generating, that should be as accurate as possible. Now, what is the parameter we are using to decide about the variation in a particular laboratory? We are getting information about the variation either with standard deviation or with the coefficient of variation. These are the two parameters. And if we want to see the variation, the same analyte over a period of time, we can use standard deviation. So that we have already calculated in our controls. Here we want to see clinical implication of this concept, of this variation. So if you recall your statistical knowledge, which you read in your Park and Park, otherwise this is not something related to preventive and social medicine, this is concept of statistics. One standard deviation covers 68.3% data points. Two standard deviation covers 95.5% data points. And three standard deviation covers 99.7% data points. 95.5 is covered by two standard deviation and 95 is covered by 1.96 standard deviation. And in this measurement uncertainty, we are covering variation in 95% data population. That is why if you see the references, they say you multiply SD by 1.96, and people who have NABL accreditation, if you see document produced by NABL 112, they have also mentioned 1.96. This is the reason behind this 1.96. They are covering 95% data population, which is covered by 1.96 SD. Now, what is the utility of this? Imagine a situation. If lab is reporting bilirubin 22.4, clinician is calling and asking, Madam or sir, are you sure about your measurement? I have to decide about exchange transfusion. And I have to take a decision if the bilirubin is more than 23. So by any chance, can it be more than 23? Because if I am avoiding exchange transfusion in this situation, an exact bilirubin is more than 23. It may cross blood-brain barrier. It will be deposited in basal ganglia, connectors, and ultimately mental retardation. This is an unacceptable situation for a child if we can avoid that. So are you sure about your measurement? So what will be your answer? Generally we say it should not happen, but maybe it is more than 23. We cannot give you any guarantee. But if you utilize this concept of measurement uncertainty, SD multiplied by 1.96 or in rough calculation by 2, suppose you're saying in case of higher bilirubin, your standard deviation is 0.2. 0.2 multiplied by 2, 0.4. So now you can see we are reporting this as 22.4 based on variation observed in our laboratory related to bilirubin estimation at higher level based on data we have generated in last 3 months. Our standard deviation is 0.2 and measurement uncertainty is 0.4, 0.2 multiplied by 2. So if we are reporting this as 22.4 with 95% certainty, we can say this will not be beyond 22.8 if we are reporting it as 22.4. clinician will also understand, yes, they are talking something meaningful. So I can wait for some time. They are keeping that child under phototherapy. After some time, 2-3 hours, they are sending bilirubin again, or maybe after 4 hours. And now suppose bilirubin is 22.7. Now the laboratory will say, see, the patient was on phototherapy and still the bilirubin has increased. Now, considering for measurement uncertainty, we cannot give you any guarantee. This is less than 23. You decide accordingly. So this is the utility of measurement uncertainty when we are reporting a quantitative result. It is not applicable in all situations. Glucose, whether it is 226 or 234 or 238, it will not affect the decision of clinician, or it is 240 or 252. It will not affect. But where it has utility, you have to decide something. Maybe related to your low value platelets, you want to see whether the platelet has really increased or this much variation can be attributed to measurement process only. There it has utility. So you have to find out where it has utility and provide this information to your clinician. And in another situation, see here, where examination include a measurement step, but do not report a measured quantity value. The laboratory should calculate uncertainty of measurement step where it has utility in assessing the reliability of examination procedure or has influence on the reported results. Now, shift your attention to a serological test for your HCV, anti-HCV antibody, HBs AG, hepatitis E virus, anti-HB small e antibody, which you measure in hepatitis B, or HBe antigen. Here you are calculating absorbance. Then you are comparing absorbance with the cutoff value. If it is less than cutoff value, negative. If it is more than cutoff value, it is positive. You are measuring, but you are not reporting the measured value. Now, suppose you are running positive control daily, definitely you will get some variation in the absorbance. When you are getting variation in the absorbance, you can calculate standard deviation. And if you're multiplying that standard deviation by 2 or 1.96, you're getting measurement uncertainty. Suppose your standard deviation on the basis of these controls is 0.1, measurement uncertainty is 0.2. Your cutoff value is 1. Suppose a patient absorbance is 0.6. This is negative, and even if you are including measurement uncertainty in it, 0.2, it is again negative. You can report this as negative confidently. But suppose it is 0.9. As per your interpretation, this is negative. It is less than 1.0. But if you include measurement uncertainty in it, if you add 0.2, this will become 1.1. What you were reporting as negative, it can be positive. Similarly, a positive result can be negative. To report this with caution, write a comment with this. This is in the borderline range. Considering measurement uncertainty, exact decision cannot be taken. And send this patient again for repeat analysis. Then we will examine this patient again for this particular test. Generally what happens, based on our past experience, we have seen this serological test gets settled on one side in this 1 week, 10 days, or sometimes 2 weeks, either in one direction or the other direction. So this is the application of measurement uncertainty, where we are measuring something, but we are not reporting the measured value. Because ultimately, what is our aim? We want peace of mind and confidence in our report. Whatever we are releasing, we are tension free. We have taken enough precautions and we are confident. If suppose after 2 weeks, patient is coming to us and previously it was 0.9 and now suppose it is 1.4, it is clearly positive. And we already explained at that time that this may happen. Sometimes reverse the situation. Previously it was 1.1, now it is 0.7. We have already explained this is not something which is disturbing us. And our patients, our doctors, they are also satisfied with our reports. So that ultimately what we are doing, whatever we are performing in our activity, we are confident about that and we are happy with the situation, right? Thank you very much.